Pleasure to be here. This is always an exciting topic to talk about. It is kind of the Wild Wild West, as Dr. Fox alluded to, and it's kind of it's not new in the world of ultrasound imaging and diagnostics and intervention, but it is kind of still very much unbroken ground, and there's still a lot to be learned, and there's only really truly a few people in the world who should be considered experts in this area. There's a lot of directions that this is going, and with this particular modality, you really need lots and lots of experience to know your anatomy, know the pathology, and be able to really trust this as a clinical modality or even replacement for other imaging. And I'm nowhere near that. You know, I'm still learning. I'm still getting started. I've only been doing it for a few years, but I did a lot of it in my fellowship training, whether it was diagnostic or interventional image guidance for injections and things like that. And then only recently starting to do more scans with the machine in the office. And so I even have a lot to go. And as we all know, some of the best ways to learn something is to teach it. And so I'm really grateful for Dr. Fox to kind of include me in the curriculum. So we're going to talk about just some concepts of musculoskeletal ultrasound, and in particular, we'll kind of talk about some general principles specific to MSK. And I know you guys have had already some curriculum in terms of knobology and the physics, and we're not going to go into any of that, but I'm going to kind of touch on things that might be specific to MSK ultrasound. Talk about the different tissue types that you can see with musculoskeletal ultrasound, and then in particular talk about kind of the characteristics of those individual tissues, some of the anatomy as we go through. As everybody's learned throughout the year, when you're doing ultrasound, your handle of the anatomy is key, and that's very much true for musculoskeletal, as well as talk about some of the pathology that we can see, and in particular we'll go by some specific anatomical regions and put it in a clinical perspective in terms of what I might see in the clinic using ultrasound and how I might use this to diagnose injury. So we've obviously gone a long ways with ultrasound and ultrasound technology, and the machines that we have now are pretty amazing. And this experiment tomorrow with Sonosite with all these handheld and the screen captures and the screen image quality is pretty amazing at this point. So some general principles. We all learn about the different transducers that are used with ultrasound, linear, and curvilinear, and the different frequencies. With musculoskeletal ultrasound, you need the high frequency linear transducer for a couple reasons. The high frequency gives you better resolution but less penetrance, and so lower frequencies give you more penetrance but less resolution. So with musculoskeletal, we're dealing with a lot of superficial structures. We're not really trying to get too deep. There are a couple regions where you do have to either switch probes or go to different settings to get more penetrance and get deeper. But in general, with MSK, we're mostly looking for the high frequency, better resolution, less depth. And we need the linear probe because of just the focal points that are variable with the curvilinear probes and things. We need a broad spectrum view, and so the linear probes are important. And there are other specific MSK transducers as well. One's called hockey puck. It's just a really kind of small, skinny transducer that is helpful for little small digits and things like that. So there are some nuances for MSK as well. There's also something called a standoff pad. It might have been mentioned at some point during some of your lectures, but when you're looking at the transducers, there's a certain focal point for those sound waves and for the crystals. And the focal point is a particular distance from the transducer, you know, kind of like how our eyes function. And so if you have if you're imaging a finger and it's a really tiny small joint and the transducer is right next to the probe, that focal point could be past the joint or too deep. And so the standoff pads basically are something that you can put on top of the finger or on top of the area. It brings the probe up off of the anatomical region, and it focuses the focal point more appropriately. So just something a little bit more specific to MSK. And in general, there's, as you guys have learned, there's all kinds of different modes for the machine. We tend to use the 2D mode, fairly basic mode. And then there's the Doppler color flow when you're looking at a lot of the vasculature and blood flow. But there's something called power Doppler, and that's a specific setting on the machine. And power Doppler is used for tissues that kind of have low penetrance of vascularity. And we're looking at tissues that tend to have low vascularity, like tendons and ligaments. and particular with pathology and different injuries, you're going to see differences in terms of new vessel formation and things like that with some of these tendon disorders. And so in general, we're using a power Doppler mode. So in general, when we're talking about musculoskeletal ultrasound and ultrasound in general, you know, it's a really huge upcoming area because there's a lot of benefits for this imaging modality between the accessibility and just having it in your office and being able to do that real-time imaging, being able to move the tendon and move the muscle and move the joint, look at the ligamentous laxity, and be able to compare that to the other side. And so if I'm looking at like at an elbow, this is Dr. Fox's computer, so I'm not sure what's going on here. Let's see, let's go back down here. Okay. Well, hopefully that'll only happen a few more times as we go along. So comparative. So if we're looking at ligamentous laxity, I'm looking at, say, an elbow ligament, and I'm worried about a tear. Exam is suspicious for some laxity, but I want to kind of better characterize and figure out how much is it fully torn, how much laxity is there. I can actually put the probe on the elbow joint, watch and see how much the bones open up, how much that joint opens up when I'm testing the ligament. And everybody has different ligamentous laxity. Some people might be a little bit looser joints than others. So I can then move to the other side, the non-injured side, and look how that side moves and be able to see if there's a difference there. And that's real time. You can't do that with an MRI. You can't do that with x-rays. It's comparative. It's in the office. It's cheap. It's safe. And there's no radiation exposure. So a lot of benefits to this modality and having it in the office. In terms of limitations, though, it certainly can be expensive. You know, these machines are not cheap, and if you're in a private practice or you're starting up a practice or even an academic situation, there is a significant investment, you know, to these machines. So there's a lot of front end costs, but it in the end can kind of pay off in terms of the accessibility for the patient and accuracy of diagnosis and different accuracy of procedures, injections. We'll talk a little bit more about that. Some of the other limitations, though, as I was alluding to initially, it really is practitioner dependent. You know, so if the practitioner isn't quite in control of their anatomy knowledge, or they're not quite experienced with the modality, you know, it requires a lot of time and a lot of investment in terms of extra education, and so it is something that takes years to get comfortable with. And as I mentioned, you know, I'm still working up to that. So it is very operator dependent. And it's important with ultrasound as well, like any other imaging modality or diagnostic tests in medicine in general, is you have to know the limitations of the machine. You have to know what it can see and what it can't see, because if you don't see it, it's not maybe because it's not there or the injury's not there, it might just be because you can't see it with ultrasound. So it's really important to know what you can and can't see, what you can trust with the ultrasound, what you can't trust. And there are limitations to the technology, and we'll touch a little bit on that as we go along. And again, that relates to kind of the depth of penetrance, and can't see through bones or deep into joints and things like that. So there are limitations. So when it comes to the different types of tissue that you can see with musculoskeletal ultrasound, in general, you know, we can certainly see those soft tissue, skin, subcutaneous areas. We see tendons, we can see muscle, we can see ligaments, we can see down to the bony cortex, and we'll go through all these different tissue types as we move along. So the first one we'll talk about is tendon tissues and kind of their characteristic image quality and what you can see in terms of tendons on ultrasound. This is a finger flexor tendon. This is the middle phalanx through here, the lining of the bony cortex. This is the tendon overlying that, and this is the subcutaneous tissue. So very exquisite, very nice view of tendon tissue. So when we're looking specifically at this, there are certain characteristics of tendons that you're looking for. So it's a very kind of what we call fibular pattern. So it's you can see the fibrils of the tendon tissue kind of interspersed throughout that view. It's very hyperechoic, meaning it has a very strong, denser signal, not quite as much as bone, but there is a dense hyperechoic image to tendons. as part of the limitations in knowing what's normal, what's not normal, there are some characteristics of certain tissues that you have to be aware of. And for tendons, there's something called anisotropy or anisotropy, depending on who you are and where you studied. But it's basically, when you're looking at tendons, it should have that very hyperechoic view and that fibular pattern. When you're looking for problems in tendons, sometimes there's disruption of the tissue. It's black, it's dark, you can't quite see it. But that might be just anisotropy as opposed to actual tear in the tendon, and we'll talk a little bit about that. And the other nice thing with tendons is, it's real time, it's dynamic, so you can actually see the tendon move. You can see it move through the whole range of motion of that joint, and you can see if there's any disruption in anatomy, at that point. So this is anisotropy, just to talk a little bit more about that, and we'll see that as we go through the practical scans in this afternoon. But what you're looking at here is this is a bony cortex right here. This is the overlying tendon structure, this fibular longitudinal pattern through here with the overlying subcutaneous tissue. Now, what the practitioner is doing right now is he's bringing the probe from what we call heel to toe, so just rocking the probe. And as you do that, what you can see is, look at this area here, it goes black, but then it comes back into view with that fibular pattern, goes black, and then comes into view with the normal fibular pattern. So if you paused it there, right at that moment where it's black, you would say, oh my gosh, there's a complete tendon tear, and there's fluid there, but it's actually just anisotropy. And so just little subtle adjustments, you can see that there's normal tendon tissue there. So you have to be careful when you're imaging tendons to look for that when you see possible pathology, to change positioning and make sure you're not just looking at the anisotropy. And basically, it has to do with how perpendicular the transducer is to the tendon. And if it's not complete perpendicular, then you're not going to get those sound waves coming back to the crystals, and so it's gonna come out as potential pathology. So again, when you're imaging the tendons, it should be very nice, consistent, homogeneous tissue, fibular pattern, hyperechoic, and again, you can see that tendon move through its whole range of motion as you flex and extend the joint space. Now, when we look at pathology with tendons and looking for, putting it in the clinical perspective of the patient and looking, is this tendonitis, or is this anywhere along the spectrum over to what we call tendinopathy, which is more chronic disorders in tendons. Tendonitis is just that kind of acute process, inflammatory process, and lots of inflammation and swelling. And so what you're going to see on the ultrasound is just that fluid, that inflammation, that swelling around the tendon. As opposed to more tendinopathy or chronic tendon problems, it's going to be more thick tissue, disruption in the actual tendon tissue and architecture. There's going to be thickness. There's going to be changes in that echogenicity in the tendon itself. And I mentioned earlier, in terms of that power Doppler, with tendinopathy or chronic tendon problems, there tends to be new vessel formation we call neovascularization in the tendon. So you put that power Doppler on, you can see some of that neovascularization that is specific to that area of pathology as opposed to the rest of the tendon. And then in general, you can see other changes, like we hear about calcific tendonitis. We typically hear about that in the shoulder, rotator cuff muscles. And just like bone, the calcific changes that you can see on this image here tend to be very thick, hyperechoic structures. So these are calcific changes within the tendon architecture through here. And just like bone, you're going to get a lot of deep shadowing below that very hyperechoic thick tissue because the sound waves don't penetrate through. So you see nice normal tendon tissue coming across, and you see this calcific change. So a nice example of some of the pathology that you can see. And then when it comes to actual tendon tears, just like any other tissue in the body, muscle, and other ligaments, you can have partial tears or complete tears, and what you're going to see on ultrasound kind of corresponds with that as well. But basically looking for that discontinuity in the fibers, tear within the fibers. When any tissue in the body tears, it's going to bleed, so you're going to see that hematoma, local fluid collection. Fluid basically is anechoic, or basically no signal, it's black. And so you're going to see this anechoic area or black or fluid collection within the tendon architecture with tearing in the tendon itself. And then again, it's very dynamic, and so it's pretty neat. You can then flex that tendon through its range of motion, and you actually see retraction of the tendon. and instead of full, nice, smooth movement. So you can actually see that tear functionally, and that can be very helpful to kind of evaluate how significant the tear is. This is just an example of a partial tear. It's a little grainy, but this is the normal tendon fibular hyperechoic pattern through here, and then more superficial is this localized hematoma, disruption in the tissue architecture, and distension of the tissue with that localized hematoma. So that's that partial disruption with focal hemorrhaging. Then complete tear, basically what you can see on this image here is this is the leading edge of the tendon, should be connecting to this part of the tendon, but there's obviously disruption there, retraction of the tendon, localized fluid collection, and if you were to take that through range of motion, you would basically see that tendon stub basically retract, and you can see that dynamically. So that can be quite helpful. So we'll move on to muscle. Muscle is another thing that you can see very nicely with ultrasound, very superficial. Just like tendons, muscles have a very specific pattern in terms of imaging. A muscle tends to be a little bit more hypoechoic. It's not as thick, it's not as dense as, say, a tendon or a ligament. So it's more hypoechoic. It has also this kind of fibular pattern, but it has to do with kind of the interwoven connective tissue within the muscle itself. So on this image here, this is superficial subcutaneous structures. This is the connective tissue, kind of fascial plane for the muscle. Deep to that is this kind of fibular striated component of the muscle. Connective tissue coming into another fascial layer here, and then deep to that, again, fibular kind of striated aspects of the muscle, deep muscle structures. So again, it tends to be more hypoechoic, but then you have that hyperechoic connective tissue fascial planes, and you can see that quite nicely on the ultrasound. That was a longitudinal view. This is short axis view or transverse or axial view, different terms for that. Again, more hypoechoic muscle structure. This is the deep bony structure here. So superficial, that is the muscle, and these are these connective tissue dots that in short axis view are referred to as kind of starry night pattern. You'll hear that term tossed around when looking at short axis view for muscle, as that starry night is just that interwoven connective tissue. So calf muscle, this is just a nice view, longitudinal view of a calf muscle, connective tissue planes, deeper fibular pattern of the muscle here, connective tissue planes, real image dynamic view moving across the distribution of the muscle. This example of muscle rupture, so this is a complete rupture. Again, just like the tendon, you'll see the retraction or the stub of the actual muscle tissue. So that should be connected to here. These are the fascial planes through here. This is the muscle tissue back here and is retracted. Partial tear, you're going to see maintenance of those connective tissue fascial planes, but you're going to see that kind of intrasubstance partial tearing of the muscle. Again, just disruption of the muscle tissue and maybe localized hematoma. This is a patient I saw just a couple weeks ago, calf or gastroc tear with a corresponding hematoma. So I'm just moving through the spectrum of the hematoma through here, and we'll replay that image. Come back through here. Okay. So as you move along here, any fluid collection or hematoma is going to be compressible, and you can use that dynamically to kind of aid in your analysis as well. But what you'll see, and I'll have a later picture of this as we talk about some of the pathology, but you'll see actual disruption in the muscle tissue, retraction of the muscle fibers, and then what you'll see is this kind of corresponding hematoma fluid collection. This is an image, courtesy of Dr. Fox, of a piece of glass that's in the gastroc muscle. So, again, you can see the fibular pattern of the normal muscle tissue here, connective tissue layers, and then this foreign body kind of jetting into the muscle tissue. And just like any other hyperechoic structure or reflective structure, you're going to see that posterior acoustic shadowing from that glass foreign body. And so, nice example of some of the pathology you can see on ultrasound. So moving to joints and more bony anatomy now. So when we're looking at joint anatomy on ultrasound, it has this kind of characteristic seagull sign. So I showed this image earlier. So this is the PIP joint, proximal interphalangeal joint, and it has this kind of joint space here, proximal joint articular surface, distal joint articular surface, and this kind of seagull bird pattern. So that's just kind of a typical thing you'll see at joint spaces, and then distally, again, joint space here with distal articular surface here. The ultrasound does have its limitations in terms of penetrating into the joint. Obviously, there's bony tissue surrounding that joint space, and so you're going to get that shadowing deep to the joint space. So there's going to be some limitations in terms of imaging, but you will be able to see the joint capsule, fluid that's in the joint, fluid distension, and I'll show a couple images of that later. So I mentioned earlier in terms of the application of ultrasound in the office, one of which is using it for image guidance or for joint injections. And we've been doing joint injections for a long time using surface anatomy and your knowledge of that surface anatomy to guide your injection and identify the joint space and identify the tendon sheath and identify your soft tissue structures. But it's fairly blind, and you'll realize once you start using ultrasound guidance to do injections, and then you have to go back and do blind injections, which I had to do after fellowship. It's a little unnerving, because now all of a sudden you can't see everything, and you can't see where the needle is, you can't see where you're going, and it is really very, very useful because, again, it's real time. You're not using fluoroscopy, which is kind of a typical modality that guides injection treatment, but it's radiation exposure for not only the patient but also the practitioners who's doing it all day. You can't wheel the fluoroscopy machine in and out of all the rooms, and ultrasound guidance is very, very nice, very dynamic, and very useful. And what we'll start to see more of, and what's already in the literature, is ultrasound guidance versus our traditional surface anatomy or blind injections is much, much more accurate. And there's a lot of literature out there, and it's just growing in terms of not only how inaccurate we are with our blind injections, and some of these numbers are staggering. Upwards of if we come down the bottom, down into 60% failure rate, 73% failure rate. Now these are maybe some outliers, but still alarming. How potentially inaccurate we can be with our blind injections, as opposed to when we compare them to ultrasound guidance, 68% versus just 3%. It's strikingly different. And so using ultrasound guidance is starting to become a standard of care for most joint and soft tissue injections as the modality grows and as more practitioners become comfortable with it. So bones, we can see very well, especially that superficial bony cortex structure, and consequently we can see pathology in bone as well, and in particular fractures. And as you can see on this image here, this is the hyperechoic cortex line for a phalanx, and you see obvious disruption in that hyperechoic line, and this is just showing a phalanx fracture. So again, very easily visualized in ultrasound, and when you're looking for fractures, you just basically see discontinuity in that hyperechoic line. I'll show you some more images of that, but again, when you look at the literature, because it is a new modality for imaging in MSK, a lot of people are trying to study this and make sure that we're not just kind of assuming what we can see, making sure we're comparing to standard of care, whether it's X-ray or MRI or arthroscopy, making sure that what we think we're seeing, we actually are seeing. And most of the studies that are coming out are showing quite a benefit to ultrasound, and that it's either as accurate or in some cases even more accurate than some of our traditional modalities. And that's true for bone as well. And then as you try to put it into a clinical perspective, so okay, great, I can image it and I can see the fracture, but can I use that to then treat the patient? And when we talk about, especially in an emergency room setting, we're doing reduction of fractures and closed reduction of fractures, and there's this one particular study showing that it can be quite successful with that. So as we run through the normal anatomy for bone and intact cortex, again, is that very thick hyperechoic line through here, this bony architecture overlying subcutaneous and muscle tissue. Here is again bony cortex through here, bony cortex through here, and when you get a good sense of what that looks like, and then you actually look at fractures and pathology, it becomes quite obvious, where you have again that discontinuity and what people refer to as step off when you're looking at fractures. It'd be nice if they were all this obvious. They're not always all that obvious, when you're looking at that top right picture. And then this, distal clavicle fracture, very, very common step-off type appearance and displacement of the bony fragments. This is a comminuted radius fracture. You'll see the continuity of the cortex line here, and then eventually you'll come into play here where you're shadowing step off to this cortex line here. And then as we move further along, you'll see another step off down to here. So there's basically 2 fracture lines, comminuted multiple fracture locations. Again, seen very exquisitely with the ultrasound.
Is it really painful for the patient to ultrasound bone fracture?
Not so much, and you actually use the site of maximal tenderness as a guide to where to image on the bone as kind of your protocol to find it. There's different tissues that when you're trying to image, you do have to, or different regions of the body, you do have to put a little pressure. But most of the time, especially with these forearm bones or bones that you're typically going to image for fracture visualization, you don't really have to push that hard. You just place the probe on the surface of the skin, and there typically tends to be a lot of fluid collection, and hematomas in association with fractures. And as we know, water and fluid helps the penetration of the sound waves, and so the hematoma actually helps a little visualization of the actual fracture. So you don't have to push that hard. So you do find that maximal point of tenderness and then visualize there.
Also, sorry if I may interrupt. With fractures, as long as the bones are not moving around, there's usually not that much pain associated with the fracture. I mean, I had a guy a couple nights ago he had both bone fracture of his forearm, and his arm was so angulated, and he was just kind of sitting around, looking around the room, sort of calm, and everybody kept looking at it like, wow, that looks like it really hurts. But it's when you start to move the bones around, that's where the true pain is. So when you're doing an ultrasound, you put so much gel on it. It's actually, you can get gel out of the refrigerator. I always keep the bottle in the refrigerator. And so you can put some chill gel on there, and then you don't even touch the skin. The ultrasound touches the gel, and then it's actually painless to do an ultrasound for a fracture. As long as you're not moving the bone. Once you start moving the bones around, then the patient will let you know about it.
For sure. All right. So and then a couple more views of bony discontinuity here, and then as it relates to actual clinical application and reducing fractures, you can see that very well on ultrasound. So this is where the patient would be painful, but hopefully at this point you've done a hematoma block and local anesthesia for the area of the fracture. And then you can see quite nicely as you're moving that fracture location and reducing it, you can see good mobility and visualization of that. And then you can then follow that up with an ultrasound image that shows good post-reduction in anatomical alignment. And if you've ever done this clinically just by traditional methods, it can be quite cumbersome because you get the x-ray, you show the fracture, then you have to kind of have the x-ray up, you're looking at the x-ray, you're trying to visualize the fracture, and you're moving it in what direction you feel is appropriate and by protocol. Then you have to splint it, and you send them back to x-ray, and then they get another x-ray, and then they come back, and you look at it, or like, oh, shoot, we're a little bit off, got to realign it, and then get it good, and then splint them and send them back to x-ray. And it's this cumbersome process, whereas you put the ultrasound machine on there, you're watching it, anatomical alignment, splint it, and we're all good. And so it can be quite useful and to the patient's benefit. So now that we kind of have a sense of what tendons are supposed to look like, bones are supposed to look like, muscle, and we've seen a little bit of the pathology, we'll kind of jump into a couple specific anatomical regions and get a sense for what you can actually use in a clinical setting, and like in my practice, sports medicine practice, what we can see, what certain diagnoses we might be able to use this for, and what they look like on ultrasound, just so you guys could get a sense of that. Hand, wrist, and finger is an area that's used a lot, mostly because, again, it's very superficial. You can see a lot of great anatomy, and in particular for some common diagnoses that we use it for, ganglion cysts, a common complaint for wrist and hand in a clinic visit. Ligamentous disruption, so specific for the hand, that ulnar collateral ligament on the thumb, the ulnar aspect of the thumb, MCP joint. It can be very easily visualized, and again, that's one area where we use that dynamic imaging. It can be very, very useful for diagnosis. Tendon injuries, whether it's your extensor or flexor tendons, decurvains, tenosynovitis, a very, very common complaint in the clinic. again, can be very easily visualized. I'll show some images of that. And then carpal tunnel is an area that ultrasound is being used for a lot, not only for imaging, but ultrasound guidance for injections of the carpal tunnel. So this is decoy veins. Some of these images are a little bit old from my fellowship training, but what you're looking at here is, so this is the deep bony cortex through here, joint space here. This is the overlying tendon tissue here, the extensor pollicis brevis, which is part of that decoy veins complex you guys will learn about more in the coming years. But there's the EPB is the one of the tendons involved in decoy veins. You can see it very nicely, very superficial. And as I mentioned earlier with tendinitis, you tend to see fluid and collection of that inflammation. And so you're going to see fluid surrounding the tendon. So what you have here is a short axis or axial view of the tendon. This is that little dot of the tendon running lengthwise as you're looking down the tendon. And then what you'll see is this anechoic or fluid collection around the tendon as kind of a halo around the tendon, or target sign we also refer to as a target sign. And so that's basically fluid that's in the tendon sheath. So that's your tenosynovitis. And you can see that very, very nicely on the ultrasound. And then this is an ideal depiction, but basically you're imaging the tendon. You can see the tendon sheath, and then you can see your needle slip into that tendon sheath and see infiltration of the fluid around the tendon itself. Also nice to ensure that you're not actually in the tendon. Intratendinous injections are contraindicated, especially if you're talking about cortisone. Certain modalities you're actually trying to target the tendon itself, but in general, you're trying to get that medicine around the tendon, but not actually in the tendon. And you can see that quite nicely when you're using ultrasound guidance. It can be quite helpful. So around the elbow, a couple very common diagnoses, whether it's tennis elbow or golfer's elbow, lateral epicondylitis or medial epicondylitis. There's multiple names for it, but you can image those areas quite well. So this is the distal humerus, humeral radial joint or capitellar radial joint, radial head. And this is the extensor tendon coming in and attaching on the humerus lateral epicondyle here. So superficial, deep bone structure, tendon tissue coming across the joint space and attaching onto the lateral epicondyle. So the tennis elbow is really a tendon disorder. And so the epicondylitis is a little bit of a misnomer, but what you're dealing mostly with is tendon pathology or tendon abnormalities. And so on tennis elbow, a lot of times you can visualize that tendon quite nicely. And this tendon has this fluid collection here, disruption of normal tendon fibular pattern. It's a little bit thicker. So this is a tendinopathy or probably a chronic tennis elbow. And you can see that quite nicely here. And again, you can direct injection treatments in other modalities, new modalities like platelet-rich plasma and some of these things you guys have probably heard about. And you can use the ultrasound guidance very well for that. Again, ligamentous disruption, ulnar collateral ligament on the inside of the elbow. Again, this is one area, like in our baseball pictures, we want to know how much laxity is there. You can see that real-time dynamic imaging as that joint space is opening up and flexing open. You can see that on ultrasound. As well as since you can image the joints very well, you can see joint effusions and joint fluid collections. So around the shoulder, this is an area that has been studied a lot because this is one area that is very common diagnosis and clinical complaint. Shoulder pain, shoulder impingement, rotator cuff tendonitis. A big reason why patients come into the clinic, and a big reason why we order a lot of MRIs. And so people are trying to find out, can we use ultrasound in the office, avoid MRIs, avoid healthcare costs, and is it a reliable modality to diagnose these rotator cuff tears or rotator cuff tendinopathies? And what we're finding with the literature is that it is very accurate and very reliable, and with sensitivity and specificity numbers that are quite remarkable in some cases, very, very, very reliable modality. A little bit more reliable for full thickness versus partial thickness tears. Again, the pathology is going to be very much more obvious when there's a full tear as opposed to partial tears. But either way, very accurate. And as you guys go through your training, you'll kind of get a sense for kind of good and bad sensitivities and specificities. And these are quite good numbers when you're looking at reliability. Also around the shoulder, you can see biceps tendinopathy. We can look a little bit at that when we go through the practical portion, as well as AC joint arthropathy. and we'll talk a little bit more about that. So this is biceps tendon. This is kind of a short axis long view short axis view of the long head of the biceps tendon as it comes up through that bicipital groove in the shoulder. So this is the humerus, and this is the bicipital groove between those humeral condyles. And the biceps tendon sits right in this little groove here. And it's a very easy thing to image, and we'll show you guys that during the practical component. But it's a very, very easy way to identify that biceps tendon. And you can see if there's any pathology in the biceps tendon. You can see if there's that target sign. So this is what I was talking about earlier. So this is the biceps tendon in the middle, surrounding fluid, and then you have the overlying subscapularis tendon and underlying humeral cortex. So you see this kind of target sign or tenosynovitis or fluid collection around the tendon. You see that quite nicely on these bicep imaging. And this is just the humeral head going into external internal rotation. And as it comes into external rotation, you can see the subscapularis coming across the top. So very easily imaged rotator cuff tendons on this modality, and you can see it quite well. So AC joint is kind of interesting one when it comes to ultrasound, because it seems like a very superficial joint, very easy thing to inject, but it's also very, very small. And sometimes body habitus doesn't allow you to locate it quite well. And if you remember, one of those studies in the literature review I showed was one study looking at AC joint injections, and the failure rate was pretty high. And so you're trying to get this little 25 gauge needle into this really tiny joint, usually doing it in the setting of joint arthritis or calcific changes. That's what you see here. So this is the AC joint. This is clavicle. This is the chromium process. This is the AC joint space. This is part of the joint fluid, calcific changes. And if you're trying to get in not only to a small joint, but there's a bunch of calcium and bony spurs around it, it can be kind of hard. But you put that ultrasound probe right on top of the shoulder. You see exactly where that joint is, and then boom, you can head right at it. And it's quite an easy injection to do with ultrasound guidance as opposed to without. The hip and groin is another area where ultrasound is being used more and more, especially in the sports arena, for either intra-articular injections, again, avoiding fluoroscopy and radiation exposure. The more superficial diagnoses, trochanteric bursitis, which is one of the most common hip complaints that I see in the clinic. Very easy injection to do under ultrasound guidance. You see exactly where you're going, very superficial structures, as well as muscle injury. So here's adductor muscle tear and associated adductor tendon. So you see this collection of hematoma, tissue disruption, and retraction of tissue in the area of tear. In the groin and the hip is an area where MRI is traditionally less reliable, and it's very hard to image some of these subtle muscle weaknesses or muscle fascial herniations. And there's things like sports hernia, which is this very nebulous topic where you could have pathology involving either hernia structures or muscle tears or tendon tears, and a lot of different things that can happen in sports hernia that very traditionally is not imaged on MRI, but we see very well with ultrasound. And these are some of the muscle tissues that sometimes can be involved in sports hernia that you can see quite well with ultrasound. Another very common source of pain in the groin in athletes particularly is a osteitis pubis, or just kind of chronic changes at the pubic symphysis, inflammation. And the best way to kind of work through your differential on that is to inject it. And it's obviously a sensitive area to inject that you kind of want to have image guidance to inject. And you can see it quite well on ultrasound and use ultrasound guidance for those injections. And then lower extremity, a whole laundry list. This isn't even all of them, of things that you can use ultrasound for with the lower extremity, whether it's your tendinopathies, again, patellar tendonitis or patellar tendinopathy, Achilles tendonitis or tendinopathy are very, very common diagnoses for patients coming into the clinic, especially in sports. And you can see these tendon structures very well. This is patella tendon. So this is the inferior pole of the patella coming down through patellar tendon, and then patella tendon attaching on the proximal tibia or the tibial tubercle. So very, very well imaged. This is that retropatellar area where you have the fat pad and a bursa, and you can see the anatomy quite well. You can see LCL quite well. You can see MCL quite well. You can't see ACL, PCL. Again, limitations of your modality and knowing what you can use it for. but you can see it for meniscus. And then around the ankle, you can visualize that those peroneal groups, ATFL, anterior talofibular ligament, all the common ligamentous structures that you see in your common ankle sprains. All these bursal sacs tend to be very superficial. You can image those quite well. And again, those muscle tears, muscle strains, full ruptures, hamstring, very, very common injury in sports, hamstring tears. You can see that quite well on ultrasound. So ligamentous injuries, this is a kind of a depiction of a normal MCL. This is joint space here, femur, tibia, and MCL. Ligaments look very similar as tendons. You have that fibular pattern, but it's a little bit more hyperechoic, a little bit more dense than tendons. So this is this dense ligamentous structure coming across here. This is proximal femoral condyle MCL coming distally, and this is an example of MCL tear. So this is a distal MCL tear. So this is the joint space here, MCL coming across, and then you see disruption of the tissue here, and then distally you see no longer any ligamentous tissue. So it's basically retracted proximally. So very well seen on ultrasound. I mentioned earlier that you can see some meniscus pathology. So this is the joint space here, femur and tibia. This is the joint capsular effusion. Again, you can see distension of the intra-articular fluid, joint swelling. And this is the meniscus that's basically displaced. It has meniscal cysts in here. So you can see a lot of meniscus pathology on ultrasound, but there certainly are zones of the meniscus that are deeper that you can't quite image, and in which case you have to rely on your MRI to image those areas. This is an example, a patient I saw a couple weeks ago, joint effusion, just kind of classic presentation of knee arthritis, acute exacerbation, lots of pain, lots of swelling in the knee. This is that suprapatellar pouch of the joint space. So the knee joint space extends pretty far above the knee in that suprapatellar pouch. And when you have a joint effusion, that area can be extended or distended. And this is the fluid collection in there. So all fluid with some joint debris floating around. This is just a chronic kind of classic osteoarthritis presentation, seen quite well. Long axis view, axial view. This is the femur right here, hyperechoic line.
Incredibly common. I see these all the time in the emergency department.
Yeah.
Effusions.
Yeah, and what's nice is, when you're doing, then you're either aspirating, not all of them are straightforward. Is this infection? Is this gout? Is this just arthritis? Is this acute hematoma? A lot of different things that can cause a joint effusion. So if you need to aspirate that fluid, very easily identified, okay, that's where the suprapatellar pouch is. There's the swelling. Stick the needle right there, and you're right on it. And so very easily visualized and very applicable to a clinical setting. So this is that calf hematoma I showed earlier, the hematoma formation. This is the retraction of that calf muscle. So this is the same patient here with retraction of muscle tissue, muscle tear. And this is contiguous with this hematoma formation here. This is another high school athlete of mine. So great example of accessibility of this ultrasound modality, and as it becomes more portable. So when I go see kids in the high schools, in the training rooms, where we don't have x-rays in the high school or MRIs in the high school, and a lot of these kids don't have even insurance, aren't plugged into the system, sometimes it's really frustrating and difficult for me to get an x-ray for a kid or get an MRI for a kid, but I can take that ultrasound machine in the training room and then slap it right on the kid's hamstring, and boom, we got the hamstring tear. Very well visualized. You can see the extent of it. How big is it? How big is the hematoma? How fast, how aggressive can we be with this kid? And I don't have to worry about him getting secondary imaging and going through all the hassles with that and expense to the family, etc. So this is one of my high school athletes just a few weeks ago with an acute hamstring tear. This is a patient I saw on Tuesday, comes in 6 months of Achilles pain, heel pain, a runner, and is basically at wit's end because he can't get back to his training, lots of pain. And what we're showing here is basically the distal Achilles tendon coming down to calcaneal insertion here. So the earlier movie was just basically showing the continuity of the tendon, very healthy tendon. This is the short axis view of the tendon here, calcaneus hyperechoic line here. And what you can see is the calcaneal insertion, Achilles tendon coming down here, and you're getting disruption of normal architecture. This was not anisotropy. As I move the probe around, that discrepancy stays there. That's a localized fluid collection disruption of the insertion. And insertion Achilles tendinopathy is a very common diagnosis and very easily visualized on ultrasound. This was a baseball player a couple weeks ago, got hit in the shin with baseball, kind of classic tibial contusion. Not necessarily something you would typically image clinically, but just a good example of what you can see on ultrasound. So I imaged it, and what you see here is short axis view of the tibia, long axis view of the tibia through here, and you can see the superficial subcutaneous collection of fluid from the hematoma from tissue disruption, hematoma here, and here you can actually see a little bit of tissue debris. Sometimes with these hematomas you get thickening of the tissue and a collection of tissue debris, which can sometimes cause other complications which you could follow on ultrasound that you might not necessarily see on X-ray or other imaging modalities. So take-home points for MSK ultrasound. A lot of benefits for this modality, especially in the world of MSK and the world of sports medicine, that real-time accessibility, very safe, and has a lot of applications for MSK imaging. You can image all kinds of different tissues, and it's important to keep in mind, though, as you're imaging those different tissues and you're looking for pathology, that you have to realize not only your personal limitations but also limitations of the ultrasound machine. As you get more and more training and more comfortable with the modality. There are lots of instances in musculoskeletal medicine where this is as accurate as other imaging modalities, and in some cases can even replace those imaging modalities, and in some cases is even better for imaging some tissue examples. And as I mentioned, it's in some cases becoming almost standard of care now for ultrasound guidance for some of these joint and soft tissue injections we used to do routinely blindly. So lots of applications, very exciting field, still very much the wild west of ultrasound imaging, but we're learning more and more as we go along, and we're all trying to get better adept at using this modality. So that's it. Any questions? Thank you.